Thank you for joining us. Today's webinar is titled Robotic Cardiac Surgery, Your Journey Starts Here. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. At this time, I'm pleased to introduce our moderator for this evening, Dr. Arman Arghami. Dr. Arghami, let me turn it over to you.
Thank you. Good afternoon, good evening, or good morning, wherever you're tuning from. Welcome to this first STS Robotic webinar series brought to you by the STS Robotic Task Force. My name is Arman Arghami. I'm a cardiac surgeon at Mayo Clinic in Rochester, Minnesota, and I serve as the STS Robotic Task Force Vice Chair. I'm joined tonight by four of my greatest friends and colleagues, Dr. Geirsson, Dr. Badhwar, Dr. Torregrossa, and Dr. Steffen. The goal of this first webinar is to familiarize you with the robotic cardiac surgery concept and perhaps show you the way and how you can get involved safely and effectively, start a program in your own institution. We have 4 presentations by our 4 guests, and there will be time at the end for a round table and discussions. As mentioned earlier, this webinar is recorded, so it's available to you offline for later review. Please type in and send your questions on the Q&A, which is right next to the share button on the Zoom, and we will review it throughout the presentations and answer it in the end during the discussion. With that, we'll start with our first speaker, Dr. Arnar Geirsson, my friend, the chair of the STS Robotic Task Force. He's a professor of surgery at Columbia University in New York, Presbyterian Hospital in New York, and the director of the Columbia Surgery Cardiovascular Institute. He's a busy mitral valve surgeon, and he initially actually developed a robotic program at Yale in 2018 and now leads this robust robotic program at Columbia. He's going to talk to us about what is needed to become a robotic cardiac surgeon. Dr. Geirsson?
Yeah, Dr. Arghami, thank you very much. Let me share my slides. I hope you guys can see this. So, yeah, welcome to this webinar, and I hope you enjoy this, and we'll hopefully can stimulate some discussion. I'm going to talk a little bit about what is really needed to become a robotic cardiac surgeon. Here are my disclosures. So I think the first thing you have to ask yourself a little bit is, why become a robotic cardiac surgeon? I think in many ways it's a progression from a mini thoracotomy to even less invasive approaches. You can really be a part of developing or being part of I would consider a complete cardiac surgery program, where a program can do a sternotomy, robotics, transcatheter, or even hybrid operation. You can basically offer everything for the patient. Certainly robotic is a destination cardiac surgery. You're really using all the newest technology. And I think you participate in pushing the envelopes and, be a member of a group of like-minded surgeons who really want to push things forward. I think in many ways you can separate robotic cardiac surgery into both intracardiac and extracardiac procedures. Obviously, the most common operation is both mitral valve repairs as well as robotic-assisted MIDCAB. I think they're the most common and probably the best way to get introduced to this robotic surgery. But there are multiple other operations being done and being developed and pushed forward, including congenital surgery, robotic AVRs, and now, more advanced total endoscopic CABG. So prior to starting, though, I think it is worth asking yourself and making sure that you're actually fully committed to become a robotic cardiac surgeon. There is some effort to this, but you also have to ensure that there is actually a clinical need at your hospital in the region you work in. You have to engage referring cardiologists, making sure that they're actually interested. And we'll go through this a little bit better in later on, but you really have to have a good support from the surgical chief of your program, unless you are the chief, and the hospital in the operating room. And you need to have a robotic team. And second to that, I think you need to kind of figure out, do you really believe in this? Is this actually good for the patient? I think that I'm not going to go into this data, but there is a lot of new evidence coming really recently out, including a publication for using the STS database, that actually shows and supports the safety and efficacy of robotic cardiac surgery compared to sternotomy and right thoracotomy. I think you also have to be honest about your abilities, and do you really have the skills? You have to be able to do the operation through sternotomy prior to venturing into robot. Robot is not going to teach you how to repair the mitral valve. It will make you better eventually, but it's not going to teach you the basics of how to repair the valve or do an off-pump coronary anastomosis. So I would recommend anybody who's interested in, go visit other surgeons, contact us on the task force or any of us here in the panel. I think most of us actually want to promote this specialty. We want to share the experience. We welcome visitors anytime. You know, so you have to go. When I started this, I visited 4 sites. You have to identify. We all do this a little bit differently, no matter what you do, and different styles fits different people. Identify a technique that really fits how you like to do it. Industry sometimes facilitate visit to observe cases, not necessarily just intuitive, although intuitive now is committed to cardiac surgery are really developing how to really commit and really educate and getting people started in robotic cardiac surgery. And maybe we'll talk a little bit more about that later. Obviously, you should attend a great workshop, which is part of the STS robotic cardiac surgery workshop, which we've had now biannually, but we're going to start doing this either every 18 months or every 12 months. Next workshop will be in this fall, and date is still due to be decided, but hopefully we'll post it soon on the website. There is also fellowships available, or you can get funding to actually go and get proctored both through the STS as well as the AATS Foundation. These often provide somewhat structure, mentors and proctors, and offset travel and lodging expenses. I think it is worth noting, that, and this was an expert opinion that was written and published in JTCVS in 2023. And it is very important to prepare properly before you decide to venture into this. There are plenty of programs that have not continued after initial starting a program, and it's not been considered to be due to the open skill of the surgeon, but due to the lack of volume and really experience specific case type for the extended robotic team to really maintain competency and efficiency. So we promoted these kind of I guess not quite guidelines, but kind of a resource to provide people with some information what the group thought that was really needed. Because you really shouldn't jump into this immediately. If you're going to do a mitral valve program, you need to have a moderate mitral valve surgery practice. You really need to know how to repair the mitral valve and have good outcomes. And you have to have some experience, minimally invasive peripheral perfusion technique. If you want to start doing robotic MIDCABs, you have to have some basic off-pump experience, and also with minimally invasive as well as perfusion techniques. As we mentioned before, try to look and what is really the need at your hospital region. You have to do a certain number of cases in order to grow and become competent. But there are some areas that just won't be able to sustain a volume that's required. Robotic surgery increases referrals, but doesn't really allow for a robust program. And I think you have to also understand is, are referring cardiologists interested in robotic surgery? Will they tolerate a little bit bumps? It's challenging to get this started, and are they really committed to support you? There's certain, if you want to go, when you start going and talk to your department chair in the hospital, what is the potential benefit to the hospital? It really raises the profile of the program. Cardiac surgery becomes a destination surgery in certain places. I think it's better for the patients, and I think most of us do. It's probably a little bit more costly in the beginning, but longer term is cost neutral and beneficials. It changes the payer mix if there's destination surgery. It reduces the length of stays and a lot of hospital resource utilization, and it can be really time stimulating to do this. You need to have access to the OR. You need to have an OR that has a robot. You need to have access to the robot when you start, at least 1 day a week. Most of us who are busy have access to the robot every day of the week. There is some investments required. You need to train the staff, and need to have time to train the staff, and actually, there commitment from the OR to be able to have access to those people to train the staff. It's very, this is a real team sport that consists of primary surgeon, bedside surgeon can either be another cardiac surgeon or a cardiac surgery PA, scrub techs, circulating nurse, and perfusion. This is the whole team, and it really is important to think about this as a team. When you start, you really need to have a consistency in the team, the same members. There needs to foster collaboration, and get the team involved very early in the process. They actually like doing this type of stuff, most of the people. When you're getting closer to this, you want to develop a training plan. Some people get internal consultants or external consultants. You have to have the surgeon and the bedside assistant are probably the key members of the team, and you should choreograph every step of the operation. Do some mock setup, do some dry runs, and take the team with you to visit other sites. They'll get really stimulated and committed to the process. When you're starting, it's going to be very important how you do your first selection. Be fairly conservative, although, you know, some people don't have the luxury to be conservative, but do make sure that you have a really safe and good outcomes when you start the program. And make sure you monitor your results. Be honest about your abilities and be critical what needs to be changed or addressed if there is such an issues. So in conclusion, I think there's no magic in set up a program. It's been developed, it's been described. Do what others has done. Don't try to reinvent the wheel. You know, you need to have hospital leadership support. The team is essential. You got to train yourself and the team. Make sure you're ready for this. Don't rush. And actually, setting up a robotic program is very rewarding for everybody involved. And obviously, it's very important for the patient and rewarding. Thank you very much.
Thank you, Dr. Geirsson. Excellent talk. Our next speaker is Dr. Gianluca Torregrossa. He's the director of robotic program at Mainline Health, Lankenau Heart Hospital in Philadelphia. He's a visionary and pioneer in robotic coronary surgery and other robotic cardiac procedures. He's going to talk to us about robotic-assisted MIDCAB, the pathway to robotic cardiac surgery.
Thank you so much, Dr. Arghami. Thank you, everyone, for the kind invitation. I will try to be brief. And tonight, after the beautiful presentation of Dr. Geirsson, I'll try not to repeat a fundamental concept, but rather to give you 3 stories and 1 taking-home message. And I hope with these 3 stories to catch up your attention and to get you to the next step in your journey or in your interest or in your pathway to robotic cardiac surgery. These one are my disclosure. First stories. In mid-1960s, the Italian Air Force was mostly composed by F-18 Sabre as the most important jet fighter. The F-18 Sabre was an American pilot, American jet fighter, and was coming off the technology of the Second World War and successfully used during the Korean War. Pilots were first trained in the 326 and then were passing the line on the F-86. My dad, and is him here in this picture on the left, he was a lieutenant in the Italian Air Force in the mid-60s, late 60s. And his course was the first one who, after the training in the MB-326, passed directly to the new Air Force, to the new airplane that was bought by the Italian Air Force, the F-104 Starfighter. The F-104 Starfighter was bought also by Germany, Spain, and other countries. And it was unfortunately named as the Widowmaker, an extremely new technological airplane, very, very different than the F-86 Sabre, that leaves no margin for error and extremely more challenging. And the question in the Italian Air Force was, after some of the death and some of the accident, was, can a new grads pilot jump on board directly on an airplane like this? And my dad had the opportunity to review some of the initial death and some of the initial accident, and saw that most of the accident were not actually involving young junior that finish their training and start with this new machine, but were mostly mid-career pilots that have not had enough experience of the F-86 and jump on this new, way faster, way more technological machine. So the taking-home message is that even if it seems way more technological, robotic cardiac surgery can be joined and is never too early to get involved. Now, never too early doesn't mean that you should start to do your first CABG as a robotic one. But it means that already when you are in training, you should spend time in the thoracic room with your urologist if you don't have a robotic cardiac program in your own hospital, or if you have a robotic cardiac program, spend time there. Be at the bedside. understand what is docking, understand the basics. And if you don't have a robotic cardiac program, try to learn from the general surgeon or the urologist in your team. Try to get involved early. Keep adding on your skills for open. As you heard from Dr. Geirsson, you cannot do a robotic-assisted MIDCAB if you don't know how to do a Lima to the LED on pump first and then off pump after. So while you are learning your basics, start to get acquainted with what a robot is and don't lose time. Get involved early on. Second story is Valentino Rossi. He was a 9 times MotoGP world champions. This one that you see in this video is considered the best overtake of the last 15 years in motorbike. You can see from a different angle. This guy was absolutely a stella, a GOAT, the greatest of all the time. And his story is very interesting because after the 4th world championship that he won, he couldn't win another world championship for 2 consecutive years. During the time, he decided to hire a previous world champion as a coach. And he went back like at school. He was in the front in the motorbike, and this senior coach was in his back, teaching him step by step what he could have done to get better. And this teaches you that you need to find a mentor. And this is absolutely true in robotic cardiac. Mentorship, as you heard from Dr. Geirsson, means visiting site. The visiting site is not one visit, is multiple time. Get in touch with him. The community of robotic cardiac surgeons are very open. Is an open community. We always welcome people. We try to identify the next surgeon who can really create a successful program, and we want to help. Try to visit frequently. Bring your team with them and train yourself as much as you can. Find a mentor at a certain point of your career that can make you win world championship back again. The third story, and is the last one, is about Eliud Kipchoge. This is the first man who was able to complete a marathon in less than 2 hours. Now, there are full professor who became full professor in physiology who demonstrated that was actually impossible for the MVO2 calculated of a human being beat the 2-hour marks. People became probably Nobel Prizes or full professor. And instead, this man did it. He actually didn't do it in a regular marathon, but he did it in a very well-organized setup. He had 42 runners. Each one of them was a professional runner running 1 kilometer each in the front position ahead of him. And he was pacing him and giving him the pace. So the team is essential in the success of impossible task. And robotic cardiac surgery is the ultimate leadership test. One of the reasons why it originally failed, as everybody says, in early 2000, was for a series of reasons. And a lot of time we blame the robot. But I believe that a lot of time we should blame the leadership skills of those surgeons in the late 90s and the early 2000s. The inability, you require a certain ability to sit in a corner of the room, away from a central position, elevate the rest of your team up, being able to conversate and talk with everybody. Is not anymore only you who can see the mitral valve through a small thoracotomy. Is everyone seeing your work in 5 different screens in your room, providing you feedback, telling you and seeing that little gap that you have between P2, A2, or that last stitch in your coronary anastomosis that was not full thickness. So it becomes a different game, and you need to be accepting the fact that everybody's there to say something and to work together. And you need to be a leader in that sense. And it takes a certain type of personality to be able to do that. Definitely not the personality of the maverick or Top Gun that wants to have everything under his own personal control in a very vertical position. You can have everything under your control, but have a very spread out leadership style. And that's very important. Robotic MIDCAB represent a great opportunity to start to get involved. Robotic MIDCAB can be basically is the continuation of a series of opportunities that you should start to develop in your own skills. Start to elevate your game in coronaries. Coronaries are most of the surgeons that we cardiothoracic surgery perform annually. And you should elevate, start your game. Start with adding a second arterial conduit. Start to go off pump via sternotomy. Start to take down a left internal thoracic artery and learn how to do it safely in your own institution, visiting surgeons and watching videos and spending time at the console. There are a lot of patients at every institution that needs this surgery, and a lot of surgeons that comes to me that tell me, well, I don't really see single vessel disease. Yeah, you don't see them because you don't offer a minimal invasive program. Once you offer and you are capable of offering a minimal invasive program, there are a lot of patients that you can partner with your interventional cardiologist to be able to treat. And these are some of the opportunity. And most importantly, you change completely the dynamics between you and the heart team made with your interventional cardiologist. Most of the heart team around looks like this picture. We are the baby birds, we are the little birds, always complaining that mama bird, the interventional cardiologist, doesn't give us enough food. Oh, that triple vessel has diabetes. He should have been receiving sternotomy CABG and instead got 2 stents or 3 stents. So complaining that mama bird doesn't share the food. Instead, when you start a minimal invasive program, you start to change the dynamic to something different. The clinical cardiologist and the interventional cardiologist believe in the benefit of a Lima to the LAD, and they know that they cannot beat a Lima to the LAD. Start to partner with them, and you start to give back patients to your interventional cardiologist. I now call my own interventional cardiologist, and I refer them cases. Can you stent the OM in this patient? Can you do the PCI on this right? And change the dynamics. You see, the clinical cardiologist coordinate the effort of the cardiac surgeon and the interventional cardiologist. Now, I want to tell you this picture is very representative of life. You see, the cardiac surgeon is still the guy here who believes that he's saving the world and is taking all of the efforts of the boat, making through the finish line. The interventional cardiologist is watching something else at the side and telling someone else that he will be out of his room in half hour and get ready for dinner, you know. But that's the life of the job and profession that we have choose. Overall, CABG is one of the best way to start to get involved. Start to build your program. Get yourself to be known in your local area as a dedicated coronary surgeon. Learn of pump. That's your first step. Actually, your first step is learn how to perform a coronary artery bypass grafting perfectly. Check your flow in your bypass grafting. Make sure that you know how to revise a graft. Make sure that you use a second arterial conduit. Learn of pump and start to get involved on how to take down a memory. And that is the game that you need to praise. There are a lot of other opportunities, small opportunity, but out there that for an early beginner in the game, pericardial window, LV lead placement, robotic left atrial appendage, these are opportunity to start to get to put a trocar in the chest and get to know something and get you and your team being more acquainted and build up that volume that we heard from Dr. Geirsson. It's so important to establish and be sure that you're successful in time. With that said, I want to thank all of you, and I'm happy to reply to any of your questions. Thank you.
Well, thank you, Gianluca. This was an amazing, amazing talk. Very engaging. Please do post your questions in the Q&A. We'll get to all of those at the end. With that, I would like to introduce the next speaker, Dr. Samuel Steffen. He's a very talented cardiac surgeon from Albert Einstein Hospital in São Paulo, Brazil, who I came to know a couple years ago. He's going to share his story, and his title of his talk is One Surgeon's Journey to Start a Robotic Cardiac Surgery Program in Brazil. Dr. Steffen?
Good evening, everyone. I'm going to share my presentation here. I think it's good. Yes. All right. All right. Good evening, everyone. Thanks, Dr. Arman, for the invitation to be here. Thanks for the opportunity to share our Brazilian experience on robotic cardiac surgery. So we're going to talk in this next few minutes about our journey, how did we get here, and how we are doing nowadays on robotic cardiac surgery here in São Paulo. So as Dr. Arman said, I'm a cardiovascular surgeon here in Brazil. We work in many hospitals here in São Paulo. We don't get the chance to work in only one hospital here in Brazil, so we work in many places. But our robotic program here, it's only in one hospital. It's Albert Einstein. So we started our program last year, and we're going to share a little bit of our experience on that. I have no disclosure. The first question we need to ask is why robotic cardiac surgery? And it's a question with many answers. We can think about many answers there's a lot of way to answer that question. But one thing that we must have in mind is we must have one common purpose to treat our patients. We have to do the best with low or no changes in quality of life. And when we look at our regular incision, a full sternotomy, it's something that we do every day. Our residents do every day. It's a safe incision. It's a straightforward incision. We can do pretty much all the operations through that. We can do AVRs. We can do mitral repairs with good results, with long-standing results, with good results in long term. But if we can do the same surgery, I'm saying the same surgery, not less surgery, not a different surgery, but the same surgery with that incision, I think it's going to be better. Our patients will be fine. They will be grateful for us, and our colleagues, our cardiologists, will be grateful also. This is one of our last patients that we did a robotic mitral valve repair. So how did we get started? How we started our program here still? So of course we went to the literature. We trying to see other centers, the people that are already doing robotic cases with good results, with published results, with papers being published, with long-term results being published. And looking at this paper from STS about the contemporary robotic cardiac surgical training, we see that if we follow a few steps, there are many of them, but I'm going to choose 3 steps that are very important. And for the next minutes, we're going to talk a little bit about them. And if we follow them, I think we're going to have success on our robotic program. And that's what we did here in Brazil. The first one, it's not even a step. It's something that it's very obvious. You need to master open cases first. You need to know how to do a good repair, a good mitral repair. You need to know how to use a neocord. You need to know how to make a resection, a replacement, and you need to get used to those long instruments from minimally invasive cardiac surgery. You need to know that. So it's not even a step. It's something that is very important before you jump in robotic surgery. But the 3 steps that I think it's very important. The first one is you have to define your team. You have to stick to it. So you have to be with your team every day, doing your open cases, doing your simulations with the same people, the same surgeon, the same bedside, the same consult surgeon, the same perfusionist, the same anesthesiologist, the same scrub nurse, the same people every day. You need to operate with those people every day. And you must have institutional support because you need to have robot access. You need to do simulation. You need to have robot access every week to train, to get the simulation done. So you need to have institutional support. If you don't, you're not going to be successful in your program. And you have to find the mentor, and you have to know if the mentor is the right one for you. If you can reproduce their routine in your program here. So you need to follow those 3 steps, and you're going to be successful. So for the next minutes, we're going to share and talk a little bit about it. Of course, we began our experience on minimally invasive cardiac surgery doing partial sternotomy. It's pretty much the same incision, the same view. So we started doing those AVR procedures with partial sternotomy. So we did a couple of those cases, simple AVR, sometimes doing bypass through the femoral vessels, sometimes doing direct through the ascending aorta in right atrium. So AVRs, plenty of them. We did many cases with big incisions like 8, 10 centimeters, and then 7, 6, 5 centimeters. We did many cases of that. And after we did some root surgeries, we did some bento procedures through that incision, and we got used with those long instruments and sometimes femoral access to the bypass. After that, so it's a 5.5 centimeters incision during those cases. And then we moved to doing some ASDs, some myxomas, ASDs that were not suitable for cath. We did some of that. So we got used to the right thoracotomy, to the femoral vessel cannulation, to the jugular vein cannulation, doing video surgeries, and then we went to the mitral repairs. So we did a couple of cases before we jump into robotic surgery. So we did some repair using video-assisted surgery. Pretty much it's the same setup for the robotic program. So the right thoracotomy, the femoral vessel cannulation, the jugular vein cannulation. So we did that with good results. It's a patient in the first day of surgery, doing very well, good results. Then after that, we needed to do a basic robotic certification. And we don't have a cardiac certification here in Brazil. So we went to the thoracic team here, and we did this international postgraduate graduation in thoracic surgery here at Albert Einstein. I did in the year 2020, 2021, and Dr. Lucas Cardoso, the other surgeon that works with us, did 2022, 23. So during that year, those years, we could, go to the robot simulation. We went to the OR and saw our colleagues during thoracic cases. We had robot access. We had plenty of time of simulation. That was very nice for us to get used to the robot. We did some simulation opening atrium, left atrium, closing it, placing some annular stitches, putting to the band, tying them, using the knot pusher. So we got the opportunity to learn about it. After that, I went to the 2021 STS workshop, and I highly recommend it. Dr. Torregrossa told about it. It's a very good place to go to meet people, to see how they do it, to see real people doing robotic surgery. And during that robotic workshop in 2022, of course, I had the opportunity to play around with the console. Here, it was in Atlanta. I was like taking Lima down in this one. And during that, I got the opportunity to meet Dr. Arman, and I saw his presentation talking about the Mayo Clinic experience on robotic cardiac surgery. And talking to him, we exchanged emails, and then we scheduled a visit to his place there. So we went to Rochester, me and Lucas. We stayed there for a week, saw some surgeries there, and got a chance to talk about it. And then we went back to Brazil and continued to do some simulation. So once again, the institutional support, letting us to have access to the robot every week was very, very important. So we got the chance to every week spend a couple of hours learning and using the robot, placing stitches around. So we stayed there every week doing that. Here in this video, you can see I working at the console, Lucas working at the bedside. We don't have core knots here in Brazil, so we had to practice lots of tying with a knot pusher here. So we got the chance to do that. And after we did everything, that I said, we didn't have the certification saying that we are able to do it in Brazil. Because in Brazil, we need to have a certification saying that we are able to do it. And we talked to Intuitive, we talked to Stratner, and we got lost in this. They didn't have an answer for us. So talking to other surgeons, other people here in Brazil, and other surgeons in North America, we went back to the United States, went to Orlando through the minimum invasive solution with Pete, stayed there for a couple of days, did a training there at Nicholson Center. I think everybody knows him. We stayed there with the Brazilian team. That's me and Lucas and Dr. Paulo, Dr. Bernardo, and some scrub nurse, a perfusionist, an anesthesiologist there. So we stayed there for a few days and got this certificate saying that we did this course. I did the consult surgeon course. Dr. Cardoso did a bedside surgeon course. And then we did a layout, the OR, what we need. We did a setup for the bypass. We showed this to our directors here at Einstein, and they allowed us to do our first cases with a proctor on site. So we did everything that I just said, and then we were able to do our first cases. So 1 week before our first case, we did a crew resource management simulation. We stayed there for a whole day, doing trying to solve some issues, robot issues, bleeding issues, needing to go back on bypass issues. So we talked during the whole day during those problems. They were like testing us in that. In the first picture here, you can see Dr. Fabio at the back of the picture. He's our chief surgeon at Albert Einstein. He was always supporting us and cheering us and saying that we are good and we are going to do it. So he supported us in all times. So we did this crew resource management 1 week before the first case, and then more pictures of that. And then last year on April, Dr. Arman came here to Brazil as a proctor, and we scheduled 4 cases, and he stayed there with us at Einstein. We did the first ASD closure, and then we did a right atrial myxoma, and then a mitral repair the third day, and then the last case with Arman with us, we did a left atrial myxoma. That's what we called a phase 1 of our program here. And phase 2 after that, from May to December last year, 2024, we did 6 cases of mitral repair with good results and without any proctor on site. We did one case with Dr. Arman at Mayo Clinic, video assisting us. He was just to discuss the case and everything, but we did those 6 cases without any proctor on site. So that's when we started our program. Arman here with us at Einstein, Lucas, some pictures of it. Here, of course, I'm not gonna talk about mitral repair, but it's the case that we chose for that day was a P2 prolapse. So we did a triangular resection, a very straightforward surgery. And then we put a band on it. That's Cardoso tying it. Unfortunately, we don't have the core knot here in Brazil, but we are planning to have it someday. We're wishing at least. So mitral valve looking good. So all the 4 cases were very good. A picture, it's me, Cardoso, Arman, and Dr. Fabio. Once again, the institutional support we had for those cases, we had 2 consoles at that day. So I was working on one, Dr. Arman the other one, seeing and proctoring us. That's the mitral case, 2 weeks after surgery. Very good results. The whole team right there. And as a take-home messages, I say that the robotic cardiac training, the robotic cardiac surgery, it's a long training, but it's possible if done the right way. And it's already written there. STS wrote it in that paper that I showed you. You need to follow those steps. But one thing that it's very important, you must have institutional support. You must have it. If you don't have institutional support, you won't have access to the robot. You don't have access to simulate it. you're not going to have success on your program. And also you have to find the right mentor and see if their way to do the surgery is reproducible in your center. If it's possible to do pretty much the same surgery there, you don't have to invent anything. Somebody's doing it very well. You just have to find the right one to see it and do the same thing in your center. And of course, it's a necessary journey. Our cardiac surgery, not only here in Brazil, in South America, but all around the world, it's necessary to do it. We need to improve it. Other people, other colleagues are doing it very well. Even the ortho guys are using the robot. So we need to improve it, and we need to use it more. And I think it's very nice to have a webinar with this talk about the journey to become a robot cardiac surgeon. My last slide is here. I just like to invite everyone to our international congress here at Einstein this year. And we're going to have our first symposium on robotic cardiac surgery in June. So hopefully Dr. Arman will be here again. And hopefully we're going to have some live cases, maybe a complex mitral repair during those days. I think it's going to be awesome. Once again, thank you very much for the opportunity to share our experience. I'm looking forward to discuss with everyone at the end. Thank you.
This was very encouraging. Thank you, Samuel, for sharing your story. It was amazing visiting your center. You're clearly a talented surgeon. Our next speaker doesn't need any introduction, Dr. Vinay Badhwar. He's the professor and chairman of the Department of Cardiovascular and Thoracic Surgery at the West Virginia University, and he's the first vice president of the STS. He's a visionary surgeon, but more importantly, he's a talented robotic surgeon. He's been instrumental in pushing the cardiac robotic practice forward, both in expanding indications and also pushing the envelope and involving new training and training new surgeons to embark on this journey. He'll be making some remarks on how STS is leading the field in robotic cardiac surgery. Dr. Badhwar.
Well, thank you so much, Arman, for the kind invitation. And really, this is a celebration of the speakers on this panel. The comments were made. It's just showing the very bright future that we have in the specialty of cardiothoracic surgery and cardiac surgery, regardless of robotics. Just the comments made and the pathway of consistency is really the general theme that you're trying to get out here. So I want to congratulate each of my three colleagues in their fine presentations. I'm not going to share slides. I'm just going to have a little conversation with you. And that as we reflect, since Randy Chitwood helped push the field forward, who I believe is watching, really we've taken lessons from him and many other leaders. They say we stand on the shoulder of giants. But now we have to evolve, and we have evolved. You've seen that pathway here. So I think Samuel may have said that, and maybe he didn't mean exactly what I'm about to say, but I'm going to interpret it, is that cardiac surgery must evolve. You're showing how, but we cannot keep doing the same thing all the time. And it's not about competition about one specialty versus another. You've heard another important theme from Gianluca about being a multidisciplinary team. It's not just surgeons in one silo. In our institution and many others, many of you here on the panel, you have outstanding cardiology partners, outstanding anesthesiology partners, all who embrace the concept. Now, we don't row on a coxswain thing like Gianluca probably does, but we functionally do the same. So I'm gonna leave you as a summarized this conversation with just a couple of broad general concepts. And I've said this before publicly, but I'll say it here tonight, that as we think about the future of cardiac surgery, and now focus on robotic cardiac surgery, I think we must embrace a concept that robotic cardiac surgery is not one operation, such as mitral or CABG or others, or a convergent or maze procedure. It's a platform. Robotic cardiac surgery is really a platform for all cardiac operations, eventually to be done robotically. So what do I mean by that? Well, we've long concentrated on For example, isolated cabbage via the left and isolated mitral repair via the right, with now a multitude of very wonderful techniques. Some of you have seen both videos and presented today that have really improved not just the ability to do the procedures, but the quality of the performance. This is a performance specialty, and that results in improved patient outcomes. Back many years ago, as we were learning the process, there were some concerns about the technique, the technology, but as Gianluca very rightly said, it's not usually the robot, it's the multitude of other accoutrements that accompany a robotic operation back many years ago. So we have to concentrate on how to keep it standardized and simplified, but to help our patients, perhaps it should not be restricted to a specific specialized procedure, but perhaps we should evolve as a specialty to be capable of so much more. And in recent years, as some of you may know, we've seen robotic cardiac surgery evolve to include newer operations, and more importantly, inclusion of multiple combinations of operations performed concomitantly. The platform is simple. A working port or incision that is lateral at the anterior axillary line, a 3-centimeter mini thoracotomy in the fourth intercostal space. The ports are at 10 o'clock in the third interspace, 1 o'clock in the fifth interspace, and of course these can be varied a little bit, and then 5 o'clock in the sixth interspace with a cross clamp or other techniques, but starting out with a cross clamp, and the third interspace at the axillary line at the level of the SVC. Of course, there's an optional camera port that can be placed anteriorly or placed it through the working port or working incision, and of course, mastering peripheral cannulation. I'd suggest as one starts to do that through a tiny little incision with essentially no dissection of the vessels, just the anterior surface and small purse strings, and that's largely imperceptible in the postoperative phase to patients. Of course, once one masters that platform, of course you can edit and adapt different techniques and technologies, some of which you've heard. But the important message I'd like to also mention is standardization, replication, and then of course education. You heard tonight from others on the ability to educate and how one goes through that journey from Samuel, which was very nice to hear. We have now consensus on education has been presented this evening with a team composition, as both mentioned by Arnar Geirsson and Samuel. And our institution, among others, have had the privilege of helping dozens of programs from around the world with this approach, and essentially all of them are fully established programs. And when we think about novel procedures, then we embrace that. And this is not, I would encourage us as a specialty, this is not the me operation. This is the us operation. It's the us field. I've said this before, but this is not a club. Robotic cardiac surgery is not a club. It should be considered as a device like any other device in your repertoire. Eventually, once one becomes facile with it, you use it to apply to a multitude of different procedures. And there are many approaches. And my comments tonight are not saying anything for or against any other method of using robotic cardiac surgery, as long as one uses robotic cardiac surgery and does so in a safe, effective, and high quality way. But the ability to be flexible and add concomitant operations, it builds one's ability to serve a wider array of patients and pathologies. This gets a little bit to what Gianluca was saying also, in that you have to do this frequently. If you only had one procedure you were going to do through a specific approach, you have to, of course, build upon them. Then I'm speaking largely about intracardiac now. Then you can somehow limit yourself. But Concomitant open biatrial maze procedures are an excellent operation in the early phase. Mitral valve replacement, of course, mitral repair. And then eventually, as one masters those types of procedures, particularly mitral valve replacements, then of course robotic aortic valve replacements, and then concomitant varieties from there. Now, Arman asked me to speak a little bit about STS and our commitment. I can tell you STS is very committed with partners or without partners on making sure that the specialty evolves. In fact, STS President Joe Sabik's theme for STS 2026 is Teaching Tomorrow Together. Now, if you think about this for a moment, robotic cardiac surgery is emblematic of this educational and strategic focus, be it through the STS robotic cardiac course that was spoken about, that we're very proud of, with our current collaborative partnership with Intuitive, or by any other means or any other partners, which I think from an STS perspective, it's about the specialty. And whatever method helps us help all of you and all surgeons, not just in the United States or Canada or Brazil, but around the world. We have many colleagues and partners that I've been very privileged to be associated with around the globe that have embraced robotic cardiac surgery and its evolution to provide care to a wide array of patients. But we will continue to support standardization, replication, and education of robotic cardiac surgery. Thank you for allowing me to join you tonight.
Thank you. Thank you, Vinay, for great remarks you made. This has been an amazing webinar. You know, talks have been fantastic. We had plenty of participants in the group, and there are some questions I want to get to. We have 5-6 minutes left, more than that, maybe 9 minutes. The first one is from a CV anesthesiologist here, and he asks, what is the best way we can support our surgeons, colleagues in robotic mitral surgery? Dr. Geirsson, you want to take on that?
No, I think, I mean, it's obviously a critical part of the operation is, you know, cardiac anesthesia, being a team member. I think it's really essential to partner with, when you start this, really partner with a specific, you know, 2 or 3 maybe anesthesiologists to begin with. You know, for example, when I initially started at Yale and then later on we went to Columbia, we just, you know, we talked about how we were going to do it, how we're going to set this up, how we're going to deal with issues related to, you know, I mean, we all do this a little bit differently, but it's really important to, you know, can't go over the patient a little bit beforehand, cannulation strategy, what you're looking for specifically. Obviously, intraoperative echo is extremely important, especially if you're doing mitral valve surgery. But, you know, there's requirement for doing something about lung isolation, of course, and being a little creative sometimes with line setup. So really critical part of the team, actually.
Thank you. I'm very excited that the CV anesthesiologist is listening to us. Thank you, Dr. Kerr. Next question comes from a friend of mine. He says he's a cardiac surgeon and he wants to get involved in robotic. He's asking whether he needs to do VATS first. And I'm going to make this a little broader and say, you know, Samuel, you showed a very nice progression from sternotomy to mini sternotomy, and then you did some a right mini thoracotomy in VATS, and then you jumped on the robot. I want everybody, the group's opinion on this, and see what you think. What are the necessary steps? Can some of this be, you know, eliminated, or do you need to do every single one of these steps? Maybe every one of you make a quick comment. Vinay, you go first.
Sure. So there's another question in the chat that's somewhat similar. An established mix surgeon questioning the advantage of then moving to robotics. I think it's thematically aligned. Look, I think doing direct vision, minimally invasive cardiac surgery through a right thoracotomy, be it MIDCAB, doing harvesting of the internal mammary artery, and then direct off-pump coronary anastomosis, as Gianluca so expertly has taught everyone. then adding robotics, or doing mixed surgery, mixed platform, which is shafted instruments. These are excellent operations, and we should be proud of everybody that's doing that. There's nothing wrong with that at all. I think once one embraces robotics, the level of performance is a complete paradigm shift. It's a quantum leap to be able to do much more technically precise things within the mitral apparatus, below the mitral apparatus, using cords, looking right underneath the anterior leaflet, being able to do multiple different things, and then adding concomitant operations. In some surgeons in Europe, they can perform concomitant operations using shafted instruments. I would submit that as you go through this progression, as Samuel outlined, and as we have established in our consensus, that yes, Arman, to your question, I think you can skip over certain things. It's all depending on your team and the skill of the surgeon and the team. But the training and the rehearsals, I think, are excellent, as was outlined tonight, regardless of how you do your steps. So we've trained programs from mini thoracotomy jumping, from sternotomy jumping to robotics. It's all possible. It's depending on the team and the training. But mixed transition to robotics is the perfect situation, because your ability to almost guarantee success is augmented.
Yeah, I mean, I can comment on a little bit. I agree. I mean, I think once you, once you start doing robotic surgery and it's much more dynamic. The accuracy of the instruments is much different. You don't have the feeling exactly, but you develop that extra skill, kind of visual, kind of feedback. But accuracy, dynamic movement of the retractor to help you see everything. And most of us, I think, who do robotic surgery, if we have to convert, we don't convert to right thoracotomy, we convert to sternotomy, because working with long shafted instruments and in 2D, after you work with 7 degrees of motions and 3D, it's just totally different. It's eye-opening in many ways.
Yeah, I totally agree with that. Once you get used to the mix, the right thoracotomy and everything, okay, it's good. You do the bypass femoral vessels, you do the jugular cannulation, you do the right thoracotomy. But once you use the robot, it's much easier to see everything because it's 3D. When you do a video surgery, of course, it's a good operation. It's a perfect operation. You can do pretty much, if you have the skills, you can do with a really small incision. It's perfect. It's good. It's awesome to have that. But once you use the robot, I think you don't want to go back to the video because it's 3D. So it's much easier to do. But I think the best way is to do the right thoracotomy, to do the mix mitrals, and then you jump into the robot platform.
Dr. Torregrossa.
I completely agree with what has been said. I think Dr. Badhwar explained it very nicely. No one here will ever tell you that a mini thoracotomy or a minimal invasive approach. We applaud everyone who has the skills, the expertise. And if you are a junior surgeon in a center with a well-established minimal invasive mitral valve program via thoracotomy, you should learn from that surgeon, because that surgeon has skills that one day somehow you are going to use it. The value of robotic is that you learn a platform that you can apply for different pathology. You are not learning one specific disease approach. And that is the benefit of the robotic. That's what attracted me a couple of years ago when I was looking for expanding the skill set in my practice. You can go from coronaries to mitral, from myxoma to left atrial appendage, from atrial fibrillation to myocardial bridges. So a large majority of procedure with a form of degrees. And the reality, I hear and I see some problems with cost. I was trained in Italy. I can tell you that Italy has a nationalized healthcare system. You go in every hospital in Italy, there is a robo who is taking some dust hidden in the urology room. So there are intuitive robo everywhere. And if you don't have one, or your hospital don't have one, just learn a minimal invasive approach is great. But there are so many robo in every room, in every hospital, and you have the opportunity to learn from a lot of your colleagues.
This was all well said. I say the same thing when somebody comes and visits me. I'm like, I'm not as talented as all you doing minimally, the stick shafted instruments. It's a lot easier once you switch to robot. You never want to go back. The next question I think it's important to note is it says, I recently talked to Intuitive rep in our institution, and he said, as of now, Intuitive does not offer training in cardiac surgery. I want to clarify that. I don't think Intuitive does any training on cardiac per se, but there's some certificate of how to use the robot that's going to be done by Intuitive, and you can talk to the rep and you get familiarized with setting up the robot. But the training is what we outline here tonight. Like the STS workshop is a very good place to start. As Dr. Steffen mentioned, we have this, we used to have it every other year. Now we're making it every 18 months. And hopefully you can join on the next one in fall of next year, this year. And that's a very good place to start. And once you see the basics, then you can connect with any of us and come and observe. And then we'll be able to proctor you and get you started with your first few cases. Anyone wants to comment on that?
Well said.
I had another question that I wanted to ask the panelists. So if somebody wants to start, do you have any suggestion? Maybe Gianluca, you can make a comment on that, whether to start with MIDCABs or cabbage or mitral.
Yes.
Is there any preference? Depends on the patient, the person's experience? Not.
Yeah, it's a good question. I think that there are many ways to go to Rome or many ways to go to New York. No, you can have very different pathway that lead to the same outcomes. The outcomes is become a proficient robotic surgeon. Reality is that if you are in a center with already an established, for example, minimal invasive mitral program, and you have volume in that center, and you want to start to implement and add the robotic platform, well, start with a mitral. You have already surgeons, maybe an older surgeon that wants to start to sit down and don't stand up at the bedside, trying to look through the thoracotomy, putting his shoulder or his neck in an uncomfortable position. Get him to be interested for his own advantage of the ability to be more familiar and better for his own spine, and the ability to teach him, because with a robo you have the opportunity to let everybody see it. But if you don't have a mitral program, if most of your volume is CABG and you come from a center that doesn't have a solid mitral game, don't try to start to a mitral game with a robot. That's a bad way to try to get into the game. It's the way in which you are not going to be successful, and you're doing only for a marketing purposes. Take the CABG, is what you do, is what you're familiar. And as I said before, upscale your game in sternotomy CABG, second arterial conduit off pump, and then go to the robotic takedown. Some of my colleagues, sometimes I tell them, try to consent the patients for a takedown of a mammary artery and then a sternotomy CABG. It's not the end of the world to add 3 small incision in the left side of the chest. You take 1 hour with a robo, and after 60 minutes you undock and you complete the takedown of the mammary via sternotomy. There is nothing wrong with doing something like this. If a thoracic surgeon is doing a thymectomy, ask him to take 5 centimeters of mammary artery on that 80-year-old guy that comes with MG, with myasthenia gravis. Like, try to find opportunity to get involved and get your game to take more mammary downs, and then get your hands into it.
Well, thank you. This has been great discussion. We are at the top of the hour. I wanted to thank all our presenters and the STS and all the great STS staff for making this happen. I wanted to thank you all for tuning in and listening and supporting this practice. With all that, I would like to conclude the webinar, and there are a few announcements that will follow. Thank you and have a great night.
Thank you so much to our moderator and panelists for your participation and insight. We would like to invite you to become a member of STS if you're not one already. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code on your screen. Abstract submissions are now being accepted for the 2025 STS Coronary Conference coming to Chicago in June. Learn more on the STS website and save the date to attend. We invite you to join the next webinar on Friday, February 21st at 1 p.m. Eastern, part of our Latin Round series. This webinar will cover current management of bicuspid aortic valve and lifetime management of aortic stenosis. Thank you and good night.